Let's get started with today's clinical topic. Dr. Taylor Manalili I don't see her picture. Is she here? Yeah. Dr. Taylor Manalili received her undergraduate degree in chemical engineering from Northeastern University and then went to Stony Brook, where she earned her dental degree as well as a specialty certificate in prosthodontics. She's a full-time clinical prosthodontist at Glidewell, and she provides valuable input to our training and education programs. Today, she's continuing her series on the restoration of implants. Digital workflows are taking over, and as we've discussed before, because of the way the lab fabricates your restoration, you're a digital dentist whether you know it or not. So today, Dr. Manalili will cover the increasingly important topic of implant impressions, the digital approach. I'm going to turn it over now to Dr. Taylor Manalili. There she is.
Thank you. Wonderful introduction, Dr. Park. Thank you so much. All right, I'm going to share my screen. I just want to make sure we are seeing the same thing here. So you are seeing just a giant one slide, correct? Not multiple.
I am seeing just a beautiful
one slide. Okay,
digital,
not the slider on the bottom. All right. Good. We were having some share issues before. Okay, so like Dr. Park said, today we are going to talk about digital implant impressions. So I've given some lectures in the past on impression techniques and soft tissue management, but I really want to focus solely on just implant impressions today. So any impression that we take is extremely crucial in dentistry, right? It comes even more so when we deal with implant prostheses. And this is because implant prostheses are super rigid, right? So whether we're restoring them with a rigid bar or even a Bruxer prosthesis, whatever we are doing, there's very little give in the prosthesis itself. And as we know, implants are not quite like teeth. They do not have PDL fibers around them. So they are pretty fixated in that bone. You have no wiggle room, like you might have a couple microns of wiggle room with your natural teeth. So really important we get very accurate impressions, however we choose to take our impressions. So like Dr. Park mentioned, technology has really kind of allowed us to utilize digital workflows in so many ways, right? So we're able to utilize it kind of for whatever prosthetics we really want to make in dentistry today, especially now, which is really exciting, are implant restorations. This is becoming such a much more of a predictable workflow than it used to be. We can do this either directly through just taking our implant scans intraorally, or when your impressions come to the lab, your conventional impressions get to the lab, a lot of times they are then converted into a digital workflow. So we have our direct workflows or our indirect workflows. So it's really exciting, kind of that technology is really taking over and moving us that direction. So so I used to teach at a dental school, and so this is one of my first students that I taught. I asked them to take an alginate, and this was one of the impressions that they took. So from there on out, I learned my own lesson watching people a little closer. But I mean, I'm sure we've all been there probably once, hopefully on a partner and not a patient, in one of our first alginates, right? But we've all done this. So I think this is probably one of the biggest reasons why I have really pushed my digital agenda, and that's just basically for improved patient comfort, right? Patient acceptance of the treatment. It improves our efficiency overall. And then on top of that, it gives us this opportunity to check our impressions, right? We get to check to see if we have any distortions or if we can clearly see our margins, if we can clearly see our impression before sending it to the lab, right? So we get a really great visual of what that model is going to look like before the lab tech pours it up, right? We've all learned to kind of analyze our conventional impressions, but it's still challenging, right? It's an inverted view of what the lab tech will ultimately see once it's poured. So ultimately, we're all going to miss things. We've all done it once or twice. And we always ask that lab that wonderful question when they call to say they can't quite see something. We say, can you make it work anyway? Right? So that is a beautiful part of digital dentistry is we get to see that very clearly what the lab is going to see. We just have to take the time to do it. Right? So one of the things that's beautiful about working here is I get to work very closely with the lab technicians on the floor, and I do get to see a lot of the challenges that they're faced with some of the scans, some of the conventional impressions we get. But I'm seeing a lot more challenges with the scans that are coming in. So today I want to take some time. I'm just going to review kind of how does the scan body work, right? Uh, in overall dental history, this is a very new technology to a lot of us. So what are the important parts of a scan body and how do we utilize this, right? So it is a little different than our conventional impression copings. So when we look at our scan body, we break it down into three basic regions, right? We have our scan region. So this region typically on this is an image of one of the scan bodies here that Glidewell Laboratories sells. This specifically is suited for the Han implant, but we do have Glidewell has their own line of scan bodies that they accept with their that will is compatible with their digital library, which I'll go over in a minute. But it's really important to check with your laboratory, whoever you're utilizing, to make sure that they're going to accept whatever scan body you're using for your patient. So that's step number one. The next step is understanding how to utilize that scan body, right? So the scan region on most scan bodies, on all scan bodies, is generally in that top portion of the scan body. And that's the portion we want to make sure is crystal clear for the laboratory to see, right? That's how they're going to take the digital impression and how they're going to align it in their software so they know the orientation of that implant in the bone, where it is in space, right? Not only in an apical coronal direction, but exactly where those threads are if they need to put an engaging abutment in that implant, right? So if we're doing a single unit screw retained implant, which is a majority of the cases that we get in this lab that are scanned in, right? We do single unit screw retain restorations. If we don't have a crystal clear image of that, we kind of are lost as to where that connection lies, right? What is that orientation? What is the timing of that implant? Okay, the next part is the body. Also an important region to scan, but it's okay if it's not perfectly crystal clear. The next part is the base. The base of the scan body is really important. We want to make sure that that is completely seated, not hung up on any hard or soft tissue. I'm going to show you some examples in a little bit of a case that was hung up, not completely seated, and how we resolve that, right? So we want to make sure, just like we do with our conventional impression copings, that these copings are seated as well, right? If they're caught up, you're not going to get an accurate representation of where that implant is in space. Okay. So this is just kind of whether you're doing that direct workflow or indirect workflow. This is just a nice workflow of what can or what does happen to your impression when it comes, right? So we have our scan body. We're digitizing it using an intraoral scan, right? Then that scan body comes to the lab. The scan comes to the lab. The scan is going to be matched in the software. So the top portion, that really important portion of the implant scan body is going to be matched in the library, and that's how the lab technician is going to align the implant. So then they're able to kind of reposition the model based on the orientation of that scan body, and they'll align the implant. And then from there, they're able to design your framework, your abutment, whatever you want, and then it's sent off for fabrication. So we're leaning a lot more towards the left side of the screen. So the green bubbles, we're doing less and less of this, but it always is an option. Okay, so what are your restorative options when we do scan? So your restorative options are fairly similar to what they would be when you do a conventional impression, right? We're still able to order a custom abutment and a cement retained crown. We're still able to order our screw retain restorations. There are some limitations with current scanning technology when it comes to impressioning implants. Alrighty, and some of those things I'm going to just point out here, or I'm going to point them out here. So factors that will influence your scan. So we have implant angulation is one thing. So if you have implants that are pretty off angle from one another, that can affect the linear deviations, right? So that is something that you may want to decide. For that case, I'm going to do a conventional impression at this point in time. Technology is getting better and better every year, so I have a feeling in the next few years this is going to be a moot point. But for now, implant angulation does affect that linear deviation. So if you have implants if you did like an all on four and something is really off angle, that is something where I would stick to, say, a conventional impression. Also the implant position. So we know when we take our scans, we like to have, if we have too much soft tissue sometimes and not enough tooth structure, too much space in between there, sometimes our scanners can get lost. So we also have to keep that in mind as we go through and do these. So if our implants are really, really spaced out, maybe that is a situation where we might want to consider taking a conventional impression versus doing a digital scan. And this also depends on what you're restoring this with, right? So if you're going to restore, say, a removable locator overdenture, not a big deal. But if you're going to do something that's really rigid, you want to make sure that that you get that as accurate as possible with no linear or angular deviations. So let's talk a little bit about when we place our scan body. Okay, so we're gonna take the scan body, we're gonna seat it. We wanna make sure that these scan bodies in general, they're never gonna be torqued down. Same with your standard open closed tray impression copings. We never torque these into place. These are simply hand tightened in. So for the most part, you can get a really good feel if it's seated, but I still always like to take a radiograph to make sure that that's seated all the way. And you want to make sure you have a nice flush connection. You want to ensure you're not getting any bone impingement, any soft tissue impingement under there. You'll be able to see, especially soft tissue impingement, the screw might not be seated all the way. You'll have a little bit of space between the scan body and the platform of the implant. So there are definitely ways to tell if you can clearly see it rather on the radiograph if it is not seated fully. Okay, so I'm going to walk you through a little bit of how I go through this. So another thing I always love to do, and I do this conventional or with my digital workflows, but one of the things I love about a digital workflow is it's so easy to visualize this, right? Easier than ever before. Sometimes we miss things when we're looking at it in our mirror. It's a different perspective. Having a 3D visual of what of the representation of the patient's mouth chairside with you is so helpful. So whenever I'm doing these single unit or multiple unit restorations tooth-borne, one of the biggest advantages of having one of the biggest advantages for an implant restoration is having nice broad contacts. So I'm always going to assess the adjacent teeth, right? So our goal here is to have nice broad contacts. We want to avoid these pinpoint contacts, okay? These long, broad contacts are desired because it's going to increase the surface area, right? Which is going to help distribute forces between your adjacent teeth and your implants a lot nicer than a pinpoint contact will. So much healthier for that implant complex. On top of that, point contacts are going to pose problems with, say, food impaction, maybe black triangle formulations, right? Formations. Increased when you have that food impaction, there's tons of studies that show over time we get a lot of caries in these cervical regions, right? Leads to periodontal issues over time. So additionally, it can kind of compromise the seating of your prosthesis. So it can make your seating time on delivery day a lot more complicated for you. you might have to play around with those contacts a little bit to get it to seat, right? So we always want to, what I always like to do is go through and assess and create basically guide planes, right? So just like we would, you can think about it like creating something for like an RPD, right? We're going to go ahead and create guide planes that are going to limit those black triangles, make nice broad contacts, and it's super easy to do that with digital, right? So, and at least assess what we want to do. So these are always conversations, I'm going to say this, these are always conversations I have with my patient while I'm treatment planning, right? So I'm always going to let them know there's a chance as when we restore this that I might be adjusting your teeth adjacent to it just to make sure that we have the best outcome that we can. So I'm always going to let them know. I never want to touch a tooth without letting them know what I'm doing, right? So ultimately, we want that single path of insertion, especially when we're doing screw retain restorations, right? Because it has to engage the implant and go between two adjacent teeth. So we want a nice, easy path of insertion, makes that seating day so much easier. Okay, so what is my scanning workflow? Like, how do I incorporate this into my assessment? I keep saying it's so much easier to do this with digital. Right. So there's three basic steps that you go through, right? With any digital impression. We've all probably tried this once, um, at least once, right? So when we're impressioning our implants, I like to do the implant impression or the prep scan first, right? And then I'll go to the arch and then the bites. Okay. So just a case example, we have our implant was placed. Patient came in, our implant was placed previously. Our patient came in with a healing abutment in there. So they already had stage 2, and now we're ready to take our impression. Tissue has healed. So now we're going to take our scan body. So we're going to place the scan body. So notice, so there's a ton of different scan bodies out there on the market. Some have short, tall scan bodies. Glidewell has recently switched to this titanium scan body, which is great for so many reasons, right? It has a new connection to it. It's single length, it's titanium, so you can easily x-ray it. Has a nice roughened surface, so it's fairly, it's pretty easy to scan it. So one of the things though is, because it's a single length, is it does stick above the occlusal table, which you can see really easily here. So another reason, once I seat it, I really love to do my prep scan and my arch scan like right off the bat. Okay, so it's seated in the patient's mouth. Now we're going to take that radiographic confirmation. So again, I'm assessing right there to make sure that that connection is completely seated. So here's an example of one that is that wasn't completely seated. So on the left-hand side of the screen, right, we see two things, right? So if the blue arrow is pointing to the platform of the connection, right? So right then and there, we see that a little bone maybe is getting in the way or soft tissue might be being pinched. Another thing that stands out to me on this x-ray, you can see that the screw isn't seated all the way. So if we look at the yellow, where the yellow arrow is pointing, you see there is a space between the head of the screw, the base of the head of the screw, and where it should be sitting in the channel. So those are two red flags to me right away that I know something is preventing that impression coping, that scan body, from being seated. So I'm going to go back in. This might be a situation where I need to remove tissue, or I might need to go in and use a bone profiler and scrape away some bone to get that to seat. Now this abutment, if this abutment doesn't seat, your restoration is not going to seat. So regardless of what you're doing, you have to go away and clear that soft tissue, hard tissue away from your platform. So whatever you plan on restoring is going to seat nicely in the future. All right, so this is step 1 regardless. Okay, so after I confirm that it's seated, then I'm going to go ahead and take my prep scan. So in this prep scan, I'm always going to capture the adjacent teeth. So the contacts and the occlusal surfaces of the adjacent teeth. And I do this because, like I said, I always like to assess my path of insertion, right? Assess those guide planes. It's really easy to miss something little intraorally, right? We always look at our preps, especially if anyone started to go digital. This is always my favorite comment when someone that does get a scanner with just tooth impression or tooth preps and impressions, right? So our preps always look beautiful intraorally. The conventional impressions always look nice. And then you get your model back and you're like, oh my goodness, that wasn't my prep, right? So I love digital scans because you can really assess your prep in real time, right? It really, I think, overall has made all of us that have gone digital much better clinicians. It's really improved our prep techniques, just what we pay attention to so much more because it's very in our face and I mean, we're our own worst critics, right? So we always want to do things to our best ability, and it makes it so easy for us to very quickly modify anything that we need to. Okay, so what I love to do here is in this initial prep, it takes me, 30 seconds to a minute to scan this. And then before I move on, I'm always just going to rotate this around and visualize that, right? I always want to make sure that that path of insertion is where I want it to be and in alignment with that scan body, because that scan body represents where that screw access channel is, right? So it's going to represent if we have a screw retain restoration, where that tie base cylinder is going to come up where your access channel is going to be. So that is where the screw is going to go through and engage the implant. So we want our whatever broad contacts we create, whatever guide planes we create are going to be parallel to that. All right, so really easy way to assess it. If anything is not to your liking, you can simply just at this point go in, quickly adjust it intraorally, and rescan this prep very easily. So really no time wasted there, and you get your delivery day is going to be so much easier for you if you do this. Okay, after that, then I'm going to go to my arch scan. So it really depends on the system that you have. So we have the iTero in our office, so I'm showing you the workflow for that. But some scanners, you kind of do that prep and arch all in one. So if you have the scan body in there, great. If you wish to take the scan body out at this point and insert the healing abutment or the provisional, you can. But if you do that, just make sure in that prep scan that you capture the adjacent teeth as well. So if you didn't capture enough of the surrounding anatomy, then you want to leave that scan body in there so the scans are correctly merged, right? So the files are correctly merged and nothing is distorted. But you can see here, you could see it better in the color mode. I actually put in the healing abutment at this point and scanned through. So you can see that's kind of why that scan body looks a little ghostly in the color mode, because it's not actually there. It's just picking up on the fact that it was there during the prep scan and nicely merging those two together. This is something that you absolutely have to do when you are taking your bite. You want to make sure you are removing the scan body. You have enough information from both arches, so you want to make sure that patient is biting down correctly. So I will always put back in either my provisional if I had one or my healing abutment before I go ahead and take the patient's bite. I don't want to accidentally have the patient bite on it, even if it's a short scan body. I don't want to risk them having some sort of plunging cusp or something that's going to get in the way of having them bite down correctly. Okay, another thing, so now I'm going to point out just some tips as we go through this. So another thing I want to point out is you have to assess your scan quality. So a lot of us now have these really beautiful color scanners. It's really nice visual for the patient. It's great to for yourself to look at when you're scanning, but you always, always, always want to assess your scan in this model mode or stone mode. So this is just, again, this is the iTero icon that we have here in the office, but you always want to switch it over and see what that looks like in a stone mode, because most of the laboratories, when you send it over to the lab, they're not seeing it in color mode. They're visualizing it in this model or stone mode. And so you want to make sure that what you see and what they see are the same. Okay. So another thing I want to point out, contacts. So a lot of times we see this all the time. A lot of reps from scanner companies will say you can go ahead and autofill any spaces that you may have missed, and the autofill is really accurate. So remember I said earlier, implants don't move, right? They're pretty rigid in the bone. They only have kind of movement, about like 3-5 microns, like super, super little movement. So if you go ahead and autofill your contacts, like this was done here, your chances of having that restoration seat are really slim. Okay, you're going to go ahead and you're going to have to adjust your contacts. If you're lucky, you won't have an open contact, right? Or it's going to be really heavy. The labs don't like it when they see this. So when you go ahead and you do this autofill feature, it's not as good as you think it is, and the labs can absolutely tell when you autofill things. So go ahead, assess this in that stone mode, and you will see it too. Alrighty, so what we're looking for is nice, clean surfaces. Clean surfaces on your scan body, clean surfaces on your adjacent teeth. Okay, so I will point out some tips on how to get that in a minute, but this is really what the goal is that we want for a nice, easy seating day and no headaches for us. So these are just some examples of some things that come into the laboratory. Okay, so again, this could just be, I mean, I've seen it on some of the scans that we do. It looks great in the first scan that I take, and then I walk out of the room while it's post-processing, and for whatever reason, the scans didn't merge properly, and the post-processing scan looks something like this. So it's really important that you go back in after it post-process and reevaluate the scans in this phase. Because if for some reason something didn't merge correctly, you don't want to send this to the lab. Okay, so in this left image, the part that they use to align that flat portion of the scan body that they're going to use to visualize and align the library, right? That portion is missing. So that scan region, that really important scan region, is actually missing from the scan. Same on the upper right, right? Where the only thing they captured is the base of the scan body. So that basically the lab can't do anything with that, right? You're going to have to bring that patient back in. And the bottom images here, unfortunately, it's a much better scan than the other two, right? But we still have some distortion. And so we really need to make sure that that scan portion is as clear as it can be, okay, for the lab to accurately align their library with your scan body. So this is the kind of image that we're looking for, right? When we look down on the scan body, whatever geometry is on your scan body that you're using, you can clearly visualize it. You look at your scan, you look in the mouth, it looks the same. No distortion, no saliva bubbles, nothing on it. So same issues we get with conventional, we can get here too. It's just these are much easier solved than they are with conventional, right? Much quicker to solve these problems. So it's just recognizing them when they come about. All right, so let's see here. Will this play? Is this gonna play on me? Nope. All right. Well, the part of this video, it's not gonna play, it's fine. The part of that video is making sure that you dry your surfaces off really well. Okay, so if you don't dry your surfaces off really well, this is what you're gonna see. Okay, so when it comes back from the laboratory, this is what you will see on when it comes to the laboratory. If you do not dry off the surface as well, these are the distortions you're going to see. And you will see this clinically too. So you'll see this rather on your iTero screen as well, or on your scanner screen as well. You will see these little distorted areas of whatever you're scanning. So this happens to be a scan abutment, two different cases here that came into the laboratory, but we see here just all these really distorted acquisition scans. And so there's a lot of guesswork that's going to go into this from the lab end, and chances are you're not going to really have a well-fitting restoration. So besides having saliva or debris kind of coming in and causing this distorted scan, the other thing I really notice on this, so these are abutments. So this could be a case where maybe patient came in and either you ordered a custom abutment or a stock abutment and you put it in the mouth, and now you're trying to scan that to get your cement retained crown. This could be a case where maybe the crown fractured from a previous case you did, or you want to change it out. You cut it off, but you're going to hold on to the custom abutment that's already in the mouth. This happens all the time in our practice, right? So we seat the custom abutment, or we have a custom abutment and we need to make a restoration over it. So we don't always want to take the custom abutment out and send it to the lab. We want to take an impression of it. Really important, just like you would a tooth margin, you have to expose the margins of your abutment. So whether it's a stock abutment or a custom abutment, the lab has to see your margins. So that's another thing on this scan. I don't see the margins of that abutment at all, right? There, 3/4 of this is subgingival. The lab is never going to be able to make a complete seal around this restoration. So when we're doing this, I know I've lectured on this so many times, and it's nice to see what people are choosing and the trends, right, that people are going in, and we see more and more people getting away from these when we're doing cement retained crowns, getting away from these stock abutments and moving towards these custom abutments. And that's simply just because the margin location, right? It's easier to control where that margin is in relation to the tissue height. It's easier for cement cleanup. It's more comfortable for the patient a lot of times. It's just overall such an easier abutment to deal with. And now with the advent of technology, the cost of these custom abutments has come down quite a bit, and it's much easier to prescribe these as well. So I mentioned really hard to, when you scan these, it's one of the biggest challenges is exposing that margin. So I do want to show just a quick video here. It's a couple minute video. Dr. Chi put this video together. It's available on the Glidewell YouTube channel if you want to go back and watch it at some point. We have a couple good videos on how to take these digital impressions. But this is just, he inserted he had a custom abutment that was inserted. And what you see here is a lot of these, part of the margins are subgingival, right? So he has to expose these margins. So you have a couple ways of doing this. The first way is you can pack cord like you would around a tooth prep. And the other way is using a laser, which he's showing here. So in our office, we have BioLase, WaterLase, YSGG. It's an all tissue laser that we're utilizing here. And he's going around and he's just troughing the tissue. So if you ever did a tooth preparation and you've troughed tissue with your laser, you can do the same thing around here. It's just really important to make those margins as crystal clear as possible before you scan. All right, so now we can really easily visualize that margin all the way around. And this way, when he gets to the scanning component, it makes it so much easier to go ahead and scan this. So as he goes through, I'm just going to fast forward through this video a little bit. You can see that those margins are very easily visualized. He's able to visualize it, which means the lab is going to be able to visualize it as well. So just another thing to keep in mind if you're going through and notice. So for this, really important to always go back through and evaluate your scan in the end. I keep harping on that, but it's true. So this is something we see all the time. So it goes both ways. So sometimes your scanner just isn't great at aligning your scans. So sometimes it's our own fault. We might leave the scanning abutment in. So the patient goes to bite down. They obviously can't bite down all the way. They're hitting a scan body that you have in there. And so we call this an open bite, right? So we capture this incorrect biting position. If you take a minute to evaluate your scan at the very end, you will very easily catch this, right? So I always like to go through and visualize the final acquisition while the patient is in the chair, so I can very easily just quickly compare the two and make sure everything looks exactly the same. Sometimes we have this posterior open bite. Sometimes we'll see here this anterior open bite. And then on this top right corner, we do see this sometimes too. The scanning, if your scanning wasn't crystal clear as you did the arches, sometimes it will overcorrect the bite. So here we see overlapping of the adjacent teeth, right? So this might be a case where the scan body was taken out, like the workflow I showed, but the software just repositioned it in. But unfortunately, when they did bite down, it looks like here as we come and evaluate this in a cross section, we see that the teeth are actually overlapping, right? Which would never, we know that's not happening. So the lab already knows that if they make a restoration on this, it's going to be really out of occlusion. It's going to be 1 millimeter or so out of occlusion. So really important to visualize this. So this is kind of what my scans look like when they come back, right? So when they're done post-processing. So I don't have the scan body in here during the bite registration, but the software will automatically pop it in there, right? So I know that obviously the scan body is not sticking through the opposing arch, but when we look down, so this right surface is looking down from above, right? Kind of that axial view looking down as you would on an x-ray, right? We're looking down on it and we see it popping through that top tooth. So that's obviously not there. It's just superimposed from the software, but we do want to go through and make sure that the patient is biting all the way down. Just one last, if I can get this to play, I will. So again, so you see the healing abutment is in, but as we go through and we do the scan, we can check that the patient is fully biting down. But as we get to the processing phase, you will see the scan body kind of pop in here. So we can see kind of some of the worse scans. All right, well, I'm gonna move on because it skipped over what I wanted. All right, so the whole point of this, we have, oh, that's good anyway, we only have 5 minutes left. So the big takeaways from today that I really want you all to go home and try to do in your offices. Keep in mind, if you are scanning a case, not every case right now is okay to do scan bodies with. Okay, so some of them really do require conventional impressions or very specialized scanning software that is out there. They require additional scanners, additional scan body types, which I didn't talk about today, but we have people utilize those when they do these big full arch cases, but it is a whole nother system. Hang in there. These chairside systems that we use now are going to get there. It's getting better and better every year. I don't think there is a need to go out and buy a whole new system at this point. But just keep in mind the distance and angles of your adjacent implants. Take 2 minutes to evaluate those proximal contacts, your path of insertion. Always verify whatever abutment you are using, whether it is a conventional or a scan body, that it is fully seated before you take that impression. Make sure you clean and dry all of your surfaces really well for the most optimal acquisition. And then you have to take the time to evaluate those post-process scans. And with that, if there are any questions, I will take them.